So this patient presents for evaluation or removal of a mobile lesion that's sitting right over his xiphoid process in his chest. This seems mobile and fluctuant, seems consistent with a cyst. It's been there for a number of years. So the only issue is here, wondering if there's a little bit of a puncture here. It doesn't relate that it's been draining at all, but it looks a little bit suspicious. So, especially because of the size of it, we're going to just do an elliptical incision so we can work with that a little bit more, and then we'll seal that back up afterwards. So again, can't feel any of that?
No.
So this is certainly another case where I definitely go slowly. As you can see, even there, it's that close to the surface that it's draining already. So again here, even though that opened up, I don't go after that right away. So I'm just going to complete the incision here. And the reason I don't is because I still want to try and keep the cyst as intact as possible, the capsule anyway. And while I recognize, so you can see that, so that opens up nicely through here. So I'm just going to use this to sort of take out the window of tissue I've opened up. This would certainly be more relevant putting this underneath if I was, if the capsule was certainly not ruptured at all, but I still think it's relevant because we're just trying to maintain this as much as possible. And you're having no pain, Mike?
No, not at all.
So you can see here, sometimes the tissue is a little bit sort of more difficult to get through than you'd think. These are all brand new scalpels, obviously the blades. Just need a little bit of a sharp dissection of the base. So just like you've seen me before, what we're trying to do here is break down as many adhesions as we can. And then we'll see how much of this we can just get to pop out for us. Recognizing the fact, and you can see it there, when I rotate that through, you can zoom in on that right, but that's the defect in the membrane there. That's where this is pushing out sebum, or keratin. So the bigger issue with this is just the fact that this is a decent sized cyst. So I'll just help that along a little bit. And it's too bad that the residents aren't here with this. You can feel when you do it. I can actually feel the adhesions breaking down as I do it. And that's hard to relate on a video. Pressure here, so you can see where that's draining out, just like that. You okay?
Yeah.
Now I'm just going to try and see if I can break down some of the posterior adhesions. That will allow us to release a little bit more. You're okay? Still no pain?
Mhm.
So I'm just going to clip this here, so it's easier to work with. You can see that's all membrane through there. How long has it been here now?
I think approximately 25 years or so. But it's gotten a little larger over time.
Certainly a good size. This is probably hard to see, but this is adipose tissue behind it.
Starting to be able to feel a little bit.
Feel
Not
a little
pain,
pressure?
no. Not pain, just a little pulling and tugging, that's all.
But I can add a little bit in and see if that helps you.
Like, it's not bad at all, so not a big deal.
Did that hurt at all there?
No.
We're almost done. Just the back.
Not a problem.
And that's the back end of the capsule there. So all we've done now is we've added a little bit more freezing so you could feel some anesthesia, sorry, because you could feel a little bit back more posteriorly. And I just want to point out, so all we do now, so if you can zoom as much as you can, Rada. See, if I avert the edges here, people who see this enough will realize you can see all the way around that there's no capsular involvement, there's no tissue, there's no membrane there. That's all taken out, and that's all clean. That's right down to adipose tissue right through here. So what we're going to do now is, because even though we took out substantial mass, this is, you know, gaping more than we'd like. So we're going to put in some dermal sutures, and then we'll suture this up. So the non-absorbable, or the, sorry, shouldn't they, the absorbable sutures or dissolving sutures that we use are chromic gut that we use to give us large sections of it. So usually I cut off a little bit. It's not the easiest suture material to work with. It grabs a lot, so it's not the most forgiving. So I always trim it just to make sure that it's a little bit easier to work with. And this is certainly a case where you need the Adson's forceps, or this becomes even more challenging. So the Adsons are the ones with the teeth on them. So because it's grabbed so much, this is one where when I do sutures, I just do one loop. And then I pull it through. This is almost like you're tying a shoe. But this will allow tension to hold. And they do studies that shows that these don't truly heal for up to 3-4 months, so especially in areas like this where it's a big area and there's going to be tension underneath it, you'd just always be well served to put in some of these sutures. So here again, I'll only do one loop. Grab the tail, tie that down. We can see already how that's closing off. It was otherwise a gaping incision. Mike, you're not feeling that at all?
No.
No problems?
No.
I just make an effort to keep this dry for the next week or so.
Okay.
So you can use watertight bandages, but
Yep.
you're almost done. One or two more, and we're finished.
No problem.
Yeah, I think wood actually. Just check this edge. Oh, should be good. Good. If we're dressing on that, we should be good.